I've got to read the evacuation procedure. A fire drill is not expected, so if the alarm sounds, please evacuate the building quickly and calmly. Please use the stairs and do not use the lifts. Once outside of the building, please gather outside the Yorkshire Bank on the opposite side of the road. Exit by the door from which you have entered the room and by the fire exits which are clearly indicated by the standard green fire exit signs. If you need any assistance in evacuating the building, please make yourself known to a member of staff. Please also make sure all your mobile phones are turned off or set to silent, and I'll have to advise that the meeting, if all or part of or all the meeting, will be recorded for future broadcasts, because we like to get things out into the public domain. Shirley, any apologies?
Yes, Chair, we've got Councillor Sam Margrave, substitute Councillor Watkins, and also Councillor Brindley.
Right, yes, yeah. Nothing from, no, nothing from Dan. Right, okay. At this point in time, Chris, I'd just like to put on record, thank you very much for actually replacing Sam. Although for the year, although Sam was down as an original member and he comes up as a substitute all the while, so people might think that he hasn't turned up, Chris actually agreed to replace Sam earlier in the year. Right, but rather than go through the procedure of going to full council, because committee members are nominated for confirmed through full council, it's just been a case that we have kept it as a substitution. Okay, so I just wanted to put that on record. Minutes of the last meetings. I think we've got minutes of the 2nd of February. Am I all right to sign those?
Yeah, very much.
Will I sign every page as well?
Just initial in the corner on those.
And the minutes of the 23rd of February. Sign those as a true record. Of course you can, Trish.
On page 12, at the top, resolved that item C, the information requested by the panel on Square Peg be forwarded to members.
We haven't had it. Don't think we've had it, have we?
Just wanted to check what that was. Anybody know? Square Peg is the group that I'm involved with, and I handed over some documentation to the CAMS people, and they were going to get in touch with some people, which hasn't happened. No.
So we need to feed back to CAMS then as to what is happening and why they haven't fulfilled what they said they were going to do.
That would be really helpful.
Just on that, I mean, we did get the information, and we have been looking into those cases. So I wasn't aware of a requirement to feed back to the Scrutiny Committee, but we have received information and have been looking into those cases.
Right. My understanding was that you'd contact some of the people who'd given their names and addresses, and they said they haven't heard anything.
I think we were trying to, we were talking about it a month ago, but what we were trying to do is look through the actual details of each of the cases first. So in terms of what needs to be done then, we have been looking at the cases. So the expectation is, one, obviously you're saying to contact families as well. Is there any expectation in terms of coming back here and providing feedback, or is it feedback specifically to yourself?
I was just going to say, have I got that minute wrong? Should it have been forwarded to Jed's team?
Yes, probably.
The information requested. Sure. I'm not sure, or should it be to the relevant family? I'm just thinking that maybe doesn't make sense from what your understanding of what we were supposed to be doing was. So.
Yes, I'm not sure, but if you're contacting the families in the imminent future, yeah, okay.
Basically, it needs to say that the information provided, right?
The panel, not requested.
Yeah. Provided by the panel. Yeah. Does that read better? Because we did provide it.
information was provided to CAMS for them to look into particular cases. I think that probably covers it from my memory.
Yeah.
And what we will do is obviously we will consult the families, but also we'll feed back to yourself, Councillor Elliott, so you know kind of where we've got to with it as well.
Fantastic.
Yeah.
Square peg. Taken forward by CAMS or something like that.
The information provided by only 2 CAMS, right, to look into particular cases.
Okay.
Was agreed. Yes, Trish? Yeah? Very much. Is there anything else? Any declarations of interest other than listed? No? No additional declarations there? Public consultation? Amazing. Amazing, yeah. Yeah, can we write to the relevant council and ask him why he wasn't attending? And why didn't he send a substitute? Over to you, our guest then. Thank you very much. Agenda item 6, young people and self-harm.
An intro, and our colleagues who actually know the detail and know what they're talking about actually take the report. But in terms of context, at the last meeting, you asked for a more detailed update on self-harm and how it affects young people in this locality. So in effect, what the report does is it kind of defines self-harm, so it's clear what we're talking about. It also gives some of the national context, and then it goes into the detail in terms of what we as a trust are doing in response to self-harm. So, do you want to introduce yourself as well?
So hi, pleased to meet you. I'm Michelle. I'm the service manager for the Coventry Warwickshire Camp Service.
I'm Claire Wigan. I'm a CAMS practitioner for the acute liaison team. I'm currently acting up lead for the acute liaison team at CAMS.
Just give some context about the acute liaison team. So the acute liaison team is a team of, and I say team, it's 3. It's 3 staff and a consultant who work together to provide a response to paediatric wards. So with regard the locality of Nuneaton and Bedworth, that is UHCW ward 14, which is the adolescent ward, and ward 16, which is obviously the children's ward. Obviously, because we lost the treatment ward a while ago, didn't we? So all referrals from Nuneaton and Bedworth go to UHCW. But also the acute liaison team respond to South Warwickshire as well, which is the Gregor ward at Warwick Hospital. So they do cover a large patch of Coventry and Warwickshire. The aim of we several years ago, when we noticed there was quite a significant rise in young people presenting in paediatric wards with self-harm, we put some cases together to develop a team to respond to those young people, to give them a positive experience and a timely response on paediatric wards. Some of the guidance that's behind young people who present at paediatric wards and our A&Es is that the NICE guidance, which is the clinical excellence we work to, states clearly that young people should be admitted to a paediatric ward, regardless really of what they're presenting with, whether there's a medical intervention needed or not, just because of the seriousness around the case of young people with self-harm needs. So that was the main reason why we presented our case a couple of years ago, to enable us to have that timely response to our young people, because we were seeing the rise locally, but obviously the national figures were seeing a rise across the whole of the country. So we wanted to do something with our own young people in the kind of Warwickshire and Coventry area. So that's kind of how the acute liaison team came about. What we have seen as well, our figures do still mirror the national context. So they are seeing different presentations of young people, and they are still seeing a rise. What we have seen though, which is we could see is kind of a positive, is that steep escalation that we saw a couple of years ago, which was why we responded with the development of the acute liaison team, we are seeing a plateau, and you'll see that in the figures that you've got, particularly for Nuneaton and Bedworth. It's still too high. We shouldn't really be having any young people that go on a paediatric ward with self-harm, obviously, but we have seen, you know, some things are changing in the way that our young people are presenting with emotional difficulties. So we've started to have a look to see how and why that is happening, because something has caused those figures to kind of start to be on a continuum rather than that steep rise that we're seeing. One of the most significant things I think that we have seen that we didn't anticipate, and neither did it nationally, several years ago when we did our business case, was we were seeing people majority presenting with self-harm in the form of cutting, so they were presenting with lacerations that required medical intervention that way. What we have seen in the last couple of years, and you'll see in the figures that we've given to you, is there's been a change in what self-harm has been with young people, and we're seeing half of those, just over half, presenting with overdoses, so they've been ingesting some sort of substances. Now the trends change, and we saw a particular trend in both young people and adults ingesting probably about 10-12 years ago, and most people might remember when we reduced the number of paracetamols that you could buy, so you could buy hundreds at one point, can't you, but now you're obviously restricted to 2 packs of 16. So we saw a trend at that point, so that was the most common form of self-harm back then, was overdosing, and then that we obviously shifted the culture nationally by reducing the availability, but we've seemed to have again gone back to the route of ingestion, and sadly paracetamol is one of those things that young people are ingesting. So some of the context behind that is I think we saw the massive change, and I think we've become a bit complacent with our paracetamols again. So it's kind of working again with those present, you know. Our young people surprise us all of the time, but also it's kind of having that national context. Obviously, one of the things is with young people who do ingest, they are going to need medical intervention. So that the aim of the service that we had a couple of years ago with our response from the acute liaison team was to try and reduce the amount of time those young people needed on paediatric wards. But obviously medical intervention is a must for young people who ingest. So we have to work with the medical team so that when they're safe to be seen and they're medically fit. So we've kind of almost come to a different approach now, because those young people are needing to be in those medical beds for longer than what we anticipated we would have needed with self-harm for cutting. So that kind of gives you a bit of a context of a plotted history of how to self-harm with our young people. Sadly, what we're also seeing is our young people are getting younger, and that's one of the things that we've been looking at. So over the last couple of years, as the acute liaison team has been working with our trusts, UHCW and our South Warwickshire colleagues, is we're collecting so much detail about what is the age of the young people that are coming through, what are the reasons, but also what's the context around them as a family and what systems are involved. So one of the things that we've also seen is young people who are under what we would see in the social care umbrella. So they're very complex families with very complicated difficulties that we can't solve just from a health perspective. So we're developing those relationships with our social care colleagues, because quite often that part of the distress that the young people is feeling is linked to the distress within the family. So it really is reliant on our social care colleagues. So there are occasions when the discharge from our paediatric wards is seemingly longer than we would like, but it's because we're trying to piece all the bits of the jigsaw together so that discharge is safe and that young person's going home, and we're not just returning them back into an environment that's going to cause them to come back, because obviously that's one of the things that we want to avoid doing. So hopefully that gives you a bit of context of the acute liaison team.
I was going to say, it's probably worthwhile just emphasising the point Michelle's making. Under 2.6, even though it's a national picture, it does give some of the reasons, the most likely reasons why young people are self-harming. So family relationships, as Michelle has talked about, is quite a significant factor. We can see a quarter of the young people that self-harm nationally is related to bullying. So those, I mean, there are a number of other reasons, but those were the 5 most prevalent reasons that young people were stating that they were self-harming. So that's part of the context into why young people do this as well.
I mean, obviously those figures, I mean, it's very difficult because the source findings that you'll see are 2014, and that's really the last time studies were done in children and young people's mental health. So you'll see a lot of reference to 2014, but obviously we're now in 2017, which is where we've been kind of collating our own knowledge. The thing that's missing there, which I'm sure most of you have noticed, is the social media networking that has just massively escalated over the last couple of years, hasn't it? But that, you know, the bullying still occurs, the family relationships are there, but the social media almost escalates that to an even bigger picture. And that's a big thing that we have been seeing is, you know, those young people are being bullied 24 hours a day now because there is no let up from social media. So there's lots of work that we as a whole system around a child needs to look at, because obviously social media is their left arm most of the time now, isn't it? So we're seeing a different challenge with regard to our children and young people and how we keep them safe from the not so nice kind of elements of social media. But definitely it is making things worse from
I'd
that
say
point of view.
probably 9 out of 10 children that we see probably being bullied for cyberbullying. So it's quite a high. There's not many that I come across that actually, when I ask about bullying, that actually turn around and say there's no bullying at all. There's a lot through Facebook, Instagram and so on, and the more it's becoming more popular and the more different sites there is and access, and the more increase it is. So I'd say bullying, the percentages on that is probably not correct in today's 2017.
And there's also a stark picture, as is highlighted there, in terms of the difference between girls and boys on the surface. And I know it's a more complex picture, which Michelle and Claire fully understand, but in terms of the collected stats, I mean, the level to which it's affecting girls versus boys on the face of things is quite stark in terms of the difference as well, which is obviously key.
I think a lot of the boys that we tend to see there are displaying it in other ways, such as anger. So it tends to be displayed in that way. They're coming across as angry and aggressive and hitting out at things rather than overdosing self-harm.
So some of the things that we've been doing is we work very closely with our paediatric colleagues, and we're also trying to make the experience for the children and young people right from the second they walk through the A&E door a nice, positive experience. We know the stigma still very much exists with mental health, and it still very much exists in our medical world of self-harm. And sadly, we still do hear those words of attention seeking, and it's not real. So the acute liaison team are embedded in the paediatric wards, and I think that's really important because we're trying to change a culture as well at the same time. We offer training to the paediatric nursing staff, so we help to support them to understand their knowledge of children and young people's mental health, but also their self-harming behaviours, because it needs to be understood in the context of the child and the young person that they've got in front of them. We also do work with the medical teams within the paediatric setting. Our challenge is, as most people will probably know, that the turnaround for our junior doctors is vast. So we can't always keep up the pace with our junior doctors because they're the ones that see the young people in the paediatric wards. But we do our best to be part of their rotation and deliver some of the support to those colleagues as well. We also are kind of trying to change the ethos within the women and children's, and we're part of their steering group, so we attend, we input into their development and each individual trust strategies as well. So we're there at the front line as well, seeing those children and people and those families, working with social care, but we're also trying to do that drip with the system around the child as well. But as I'm sure you can imagine, I'm a team of 3 and a consultant. It's we're stretched quite thinly at some times. Some of the things, when you look at in relation to the figures specifically for Nuneaton and Bedworth, and you'll see there's peaks and troughs. They're not unusual peaks and troughs. And if we put a kind of a mirror over for the referrals into our single point of entry for CAMS service, we know that they're the times that we see more referrals as well, and we're able to recognise November is always a difficult time for young people. We have lots of things happening in their lives at that point. Christmas is a big one, but also mock exams are another one, and the starting for transition points for our young people is also starts to hit in at November time. So that's when you have your year 11s being told to work really hard, because if they don't get their GCSEs, they don't get the A levels. So it's a big pressure point for our young people at that point. We also see, as you would expect, an increase after Christmas, because it's that realisation, sadly, and I don't think that's unusual with most mental health services, that time of year is quite a difficult point. But also in the Easter, you'll see as April and May, when the exams are happening, it's also the time when our young people are finding, again, a transition point. When you think of sometimes some of the difficulties of our young people, because we do see more young people with an ASD diagnosis as well who are presenting with self-harm, they're coming to an uncertainty point of change because their routine of school is coming to an end and the summer break is starting, so it does cause more anxiety. So there are key points within all parts of our service, but we do see it obviously as well in the self-harm figures. Our August and July are always our low points. One of our main referrers are schools, so we do see that dip in the summer holidays throughout our oral service. But also most of the summer holidays are busy for young people. They do go away on holidays, they do these things, so that's a natural dip in all of our parts of our service anyway. So it'd be nice if we could bottle that from August and be able to kind of give it through all the months, but obviously we can't. So there are things that we're seeing. Hopefully that kind of gives some context.
I think from a nerdy performance point of view, because that's we've got experienced and very expert clinicians. I'm just a nerdy kind of performance person really, and I think it's important to reflect, in spite of the fact it's a very small team and they've got to cover quite a large geographical area, they do every single one of the referrals that are required, the assessments are required within 48 hours, because the target is 48 hours to do the assessments following a referral, and they're always achieved. 100% is the standard output of the team in terms of doing those assessments. So in terms of those young people getting the assessments that are required when they need it, those targets are hit.
Yeah, I mean, would it be helpful if Claire talked you through the pathway of how our young people go through the journey? Would that be helpful?
So basically what happens is someone will present to A&E, so either George Eliot, UHCW or Warwick Hospital A&E, and they'll present with, on your first page you've got a definition of self-harm there, on the first bit there, so you just have a brief read. So they'll present at A&E after having maybe overdose or suicidal ideation, self-harm, and basically assessment is carried out by the medics within the hospital. So they'll see them and then they'll triage them. So if it's during our working hours, it might mean that they call us up and have a conversation with us, and we might discuss seeing them as an outpatient, or they'll be admitted to the ward. If they've overdosed, then it's obviously they need to be on the ward because they need to have the blood stain and so forth, and might need some treatment. If, say, for example, there was a young girl the other day that had self-harmed, but she wasn't expressing any suicidal thoughts, she'd been self-harming for a little while and she didn't need any treatment, so therefore I saw her as an outpatient and arranged that rather than her being admitted to the paediatric ward. So the triage will sort of be made there. If the risk is obviously too high, they'll be then admitted to either UHCW, so from George Eliot Hospital they'll go to UHCW, or obviously at Warwick Hospital. So on the ward, we'd then get a referral once they're medically fit, come through ourselves, and that will go through a single point of entry, through CAMS, and then titrate down to ourselves. So in the morning, every morning, we call round all the wards, which is Ward 14 and 16 at UHCW, and then McGregor Ward, and we ask how many people they've got for us to see. So they'll go through it and we'll collect all the data. And then it's a case of who does what for the day. So then we'll go out and do an assessment. The assessments take around 2.5 hours. If they're not known to services, then obviously we're getting all the previous history and details. So we're doing like a thorough risk assessment and then deciding whether they're safe to go home. We'd also be talking to the parents as well in that time, and social services if they've got them involved, or referring to social services if needed. Then if they were going home, for example, they'd go home and we'd see them within 7 days, so we do follow-ups. So the week after we'd see them for a follow-up, which usually takes around half an hour to an hour, and that's just checking in how they've been over the last week and where we go from there. If they wasn't safe to go home, it might mean that we get our consultant to see them, so they'll remain on the ward, and I'll be looking for inpatient unit, or if it's quite risky, then it'd be looking at them to assess that, or medication. It might mean that they need to start medication. Once we do the 7-day follow-up, we'll then either refer into CAMS, and by that we would sort of bypass the assessment because we've already done it, so it'd be the case of asking for a 4-week review, an urgent allocation of a CAMS worker, or we would refer to other services such as REACH, Compass, IAPT, things like that. So other services that offer one-to-one counselling, but are through other services not necessarily coming into our trust. So we'd put them referrals in as well. So that's a bit on a basic level of what we do.
So we make sure they're safe. We make sure that they're safe post 7 days as well. One of the biggest things we do notice is that 7 day often gives us a different sense of how that young person is managing and also how the family are managing. The other things that we're trying to put in place is our primary mental health team colleagues who work with our early help, so they're trying to help support the system around the child. They deliver a specific training package which is open to all the schools in Warwickshire, but also all the social care staff in Warwickshire. So they've been rolling a self-harm workshop which runs for half a day. It's a busy workshop. It's 9 till 12:30 and it is full on all the way through. But it's about raising the awareness of self-harm and also about giving some tools to our teachers and our SENCOs and our social care staff so that when that young person presents with self-harm, that they're not panicking. In fact, one of the things we put in the presentation is you look like a duck on the surface, you're paddling away underneath, but it's about that calm and giving that trust that young person needs and how to support that need. So we've been rolling those out for quite some time. We've got 21 school staff attending between now and July, which is great, and I think it's about 10 social care staff, and they come in a range of different kind of skills and practitioners. So those are the kind of things that because we obviously want to start to make a difference from the beginning as well, and it is, schools are our biggest, probably, you know, when it's the battle against mental health and self-harm, obviously us working with schools is the biggest tool that we've got as a combination to work together. So definitely that's something that we're kind of working towards to make a difference. So,
We're also looking at groups, aren't we, as well? So we've created some groups for parents and for the children. So they're probably going to be rolled out around May time because at the minute we're short staff. So it's a case of waiting until we're a full team again and then starting them. So we're going to offer groups to the parents as a one-off self-harm group. So educating them on things that they can do, and also a one-off one for the children's as well. So it might be that 1 month it'll be for the children and another month for parents. And we're going to try it and see how we get with it, and then increase it where needed and try and do it over the different areas over Coventry and Warwickshire. And we've created loads of booklets of different support and self-harm booklets. So on the ward we'll give a resource pack as well to the parents and to the child or young person, so they get information, support services and different lists of where they can go in the meantime and services they can access as well. That's something we're sort of building on as well, trying to incorporate more into it.
So that gives you a picture of kind of self-harm and what we're doing in response to it.
Right, thank you very much. Who's first? Any questions? Observations? Yes, Trish.
You mentioned ASD diagnosis. Just wondered if everybody knows what that is.
So ASD is autistic spectrum disorder, so young people that are presented with what we would see as a neurodevelopmental, so young people that struggle with social situations, struggle with management. It's very linked to anxiety. You know, the young people with an ASD diagnosis often struggle with a high level of anxiety than with those young people without an ASD diagnosis. It's something that we are seeing an increasing referral for us to give a diagnostic assessment for ASD, and we obviously have our colleagues in the neurodevelopmental service that we work closely with, but we are seeing, well, one of the reasons, you know, there's lots of theories of why, but we're far more in tune to our young people and their needs, especially within education. So, you know, it's not that there's more ASD than probably there was 30 years ago. We're just better at seeing it, and we're better at trying to work with these young people. But with the pressure of the world as it is as well, certainly social media and young people with a diagnosis of ASD, the combination sometimes can be very difficult to manage because of the context of understanding the boundaries and the social world attached with it. So yeah,
We've seen a lot of that as well that are not necessarily diagnosed. So it might be that they're 15, 16 and they've not been diagnosed. But a lot of girls tend to sort of mirror other girls, and it's quite difficult to diagnose them. So we'll sort of pick up during our assessment that they've got traits of autism. Then it's a case of referring to the neurodevelopmental team to get that assessed properly. And what you'll find is that actually a lot of them have probably struggled a lot through school, and it's not necessarily been picked up, and it's sort of coming out in them later years with the self-harm as well.
Bill.
Thanks, Chair.
I had a...
Oh, sorry, you haven't finished. May continue.
I just wanted to make sure everybody knew what ASD was, and it sounds like you have considered the fact that it's more girls self-harming than boys is because they are diagnosed, and so that sounds reassuring. But the other questions on the reduction in cutting and the move to tablets. I know that the school self-harm kind of advice, well, I think it's to kind of put a band on and use that instead of cutting, so they haven't got that as an outlet anymore. But I don't think the young people know how damaging taking tablets can be, and I don't think schools educate on that, and perhaps is that something that's in the pipeline?
Definitely, and the workshop that we offer is about destroying some of the myths, because there's lots of myths around self-harm that still exist within the system, so it's about kind of doing that, but also, yes, absolutely about raising the awareness and looking at the strategies. And we will work with schools, so we will do a general package, workshop, but we will always say to schools, if you've got a particular problem that you think is happening, say for your year 8s, we will come and do some bespoke training with you so that you can start to recognise. It is about helping the school build a bigger picture as well. Going back to what I was saying about, I think we as a society have become complacent about medication, and I think that's something that we all kind of need to own is, the paracetamol, this 10, 12 years ago, it was everywhere, it was in the media, it was really difficult to kind of see the damage, but I do think you're right. I don't think young people necessarily recognise, again, the damage of what paracetamol can do. And we see less aspirin, and I think that's because we use less aspirin as a society now. But 15 years ago, most people were prescribed aspirin by their GP for some reason, because it was seen as the medication that was taken. But we do see less aspirin, so there is something about the evidence that it's society that also needs to manage and take responsibility for that. But
we do educate the young people on the ward as well, and obviously when they're coming in with overdose, we do sort of tell them the reality of it and the effects that it does have upon them. And as well, we do ask the parents to remove any means, so it's about looking at them removing shots, removing any medication from the house, and locking away those that need to be in the house. But I don't think a lot of them realise the intensity of how, when they do take quite a large amount, they generally don't realise.
Yeah, working in school, we haven't had any advice on the damage of tablets.
We link in a lot with the school from the acute liaison team, so we do try and ring where possible, and we advise that they call us if needed, and we link in with a lot of the school when they've got counsellors or pastoral support and psychology services. We do try and link in with them so they know sort of where we're coming from our end as well.
I think one of the big challenges with schools, just to add to that, is with a team that is very small, so acute liaison team, 3 and a bit people, and even the primary mental health team is a small team, and the number of schools there are across the county, and it's just the ability to provide support and advice for that vast range of schools. It is challenging, let's say.
In an ideal world, you'd have a mental health nurse sitting in a school, and I think that's the ideal.
Just a leaflet on what damage taking 30 paracetamol can do to your insides, and what the treatment is.
Yes, and then realising.
And it is really interesting because there's lots of story, research about shock tactics and whether they work or not, isn't there? So it's about giving the message in the right way to young people so that actually they do see it, but don't think that will never happen to me, because that's quite often, our smoking campaigns and our drinking campaigns are all based on shock, aren't they? But don't necessarily change some of the things that we do. So.
Bill?
Yeah, thanks, Chair. It could be seen as rather a gloomy picture that's painted about it, and there's so many pressures on young people these days. But the positives is the work that people are doing with it, albeit that there's not enough of them and not enough finance to do it as well as they could. And I was a little bit concerned with the nerdy bit about praising people up 100% stuff, and that's fantastic. But history sort of says be careful when you do that, because they seem to be covering all that very well. We can take somebody out of that and save some money. So there's a balance to be struck. But Chair, we can talk as much as we like around the table here, but as a scrutiny panel we should be kind of digging into it and finding out what we can do to try and help support people. And whilst as a local authority we probably can't do a lot in regards to finance, what we can do is try and put some pressure on other people you know, to be looking at these things. Because it particularly struck me this week with the government's announcement of putting some more money into family intervention, early family intervention. The recent past has proven that can help. It can help the families and it can help this type of thing as well. But £30 million across the country is a very small amount of money, and bearing in mind they put money in, then they took money out, and now there's a bit of money going back in. And it may be that we sort of need to make representation somewhere. I guess this goes to Cabinet after this, but you know, to be talking to those in the know, the MPs and the Cabinet members at government, about further support for families. And if it's a question, I was just wondering how much of an evidence base you've got with that early intervention of that. It's also been proven in the past, Chair, early intervention in the sense of publicity campaigns about all sorts of health issues. But over recent years, it's fallen away and things are starting to return. If I give one example, I know it's not yours, but the AIDS campaign years ago had a tremendous effect on that, and now it's starting to rise again. So, you know, it shows that all that stuff that Tricia was just talking about, you know, getting that information out to people can actually work. Instead of leaving it until dealing with the after effects. Another question is, I'm interested in the paediatrician side of it. Does the paediatrician that works with your section, is it a different paediatrician that, say, works with babies as well, or...?
Sometimes it very much depends on their rotation from a UHC. I mean, UHCW is a huge hospital, and as you all know, and their rotation, we can never really catch up with how it works, to be honest. But we do work with consultants that will work with the whole of the breadth of a young person's age, so right from baby up to.
Right, so it could only be. I mean, I don't know how many are based at the George Eliot paediatricians.
I don't know.
Well, I don't know if there's 3. I know I spoke to 3 the other day.
Yeah.
3.
Within, I'm not sure how many. But they do rotate quite often, so you don't tend to get, like the one I spoke to one the other day, it was a locum for the day, so they were going off after, so it's quite difficult to link in directly with them. But on the wards as well, they do have, I know on, say, Warwick Ward, for example, they have babies on the ward and things like that, so they're dealing with 0 to 16 and 17.
Yeah. I mean, I understand that, you know, we don't have a paediatric unit as such now, the referrals go to Walsgrave. But I'm concerned about the paediatrician side of it, if that was ever to be threatened, you know, and that's why I was asking how many there are really.
There's a couple of things that you said that's probably worthwhile giving some good feedback or response to. One is to do with the, in effect, the early intervention and prevention side of things, which is one of the things you were asking about in terms of the strength of that. And I mean, this is anecdotal, so I couldn't quote evidence to support this, but generally in times of austerity or financial challenge, quite often resources get taken away from the kind of health promotion, public health, early intervention prevention side of things, which in the long run is obviously not the right decision. So there is something generally about how we make sure that public health messages, health promotion, early intervention is still prioritised as a system to the level it needs to be, because otherwise we're just storing up problems going forward. So that is something that's important, I think, for there to be kind of scrutiny over. There's also something about the alignment of resources. Some of it is about how much resources are put into, for example, acute liaison, which is definitely a big thing because a team of 3 and a bit for the county is small. But there's also something which Michelle's highlighted, which is about how can we also make sure the system works together as efficiently and effectively as possible. So using social care as an example, if we know that young people that pitch up at acute may have mental health difficulties, but may also have social care issues, the need for social care and mental health services to work seamlessly together is really, really important. So there's something about how we make sure services work together better as well. Another part of the system, which we touched on with schools, is how can we make sure that schools are enabled to identify things early and to manage things at the lowest possible level as well. So I think there's a number of different things that can be done to make the system work better. Some of it's about money, some of it's about how we get organisations or agencies to work together better as well.
Yeah. And just finally, Chair, I think it's important I mention about how we make representations, and I think we should to whoever we can, you know, to the MPs and wherever. And I mean, we're seeing it on a daily basis now, particularly the effects of social media. You mentioned it. I'm trying not to repeat it, but there needs to be more effort done by at a government level to try and get the social media people like Facebook and these sorts of providers, for want of a better word, to monitor their systems better and to restrict the type of use that's currently going on. We may be a small voice in things, but I think we can make that voice heard in the right places, you know, to support those things for making these people more responsible. Thanks, Chair.
Thank you, Bill. Caroline, steady ladies.
Well, I just wanted to make a comment about the link between mental health and social care. And it's just sort of a local anecdote. At Stockingford Children's Centre and Nursery School, we used to have about 150 hours a week of family support, and family support workers were going to people's homes that had mental health problems or postnatal depression and things like that, or problems with housing. The housing was poor, they might have debts and so on, and all those crushing things that lead to mental health problems. They would go out and do that. And we've lost 100 hours a week. We're down to one full-time and one part-time family support worker from 150 hours a week. But the problems haven't gone away. The problems are still there in the community. We just haven't got the staff to now go out and support them. So I'm not surprised that you've seen a rise also. The other thing is, I can't say it's definitely linked with that, but we've had an increase in referrals of our nursery school children with mental health problems, most notably anxiety and that heightened panic disorder, you know, that flight or fright thing. And so they're not able to learn because they're in that heightened state all the time. And we've had about 5 referrals to child psychology in the last few weeks for 3 and 4-year-olds presenting with those problems. And it just makes you wonder if that's gone up because the family support's not there anymore. So that's, just wanted to make that comment.
I think there definitely is a link. I think we've seen that link as well, and some of the families that we would have worked with, the family support workers, their criteria is that, you know, everybody's threshold increases, don't they, when things are restricted. But I would definitely remember what you're saying. Some of the things that we've been trying to also do is linking with the early help locality panels that have been established in the local authority. So sitting around the table with the you know, family support workers, the benefits, you know, those people that are trying to make the system better for the family unit. But we are seeing that, you know, the thresholds are getting more and more up, and actually I think we are missing a trick as a society to get in at that early point, and those 3 and 4-year-olds are likely to be a response of the adults with their own emotional distress, and it's, you know, it's not their fault from an adult point of view, and it's not the child's fault either. But yeah, I do very much think there's something good about the whole of this kind of taking up.
Chris,
I've got sort of observations and questions. Some of the questions I'll probably feel a bit awkward about asking, but as a scrutiny member, I've got to ask them. Is you've got the divide between boys and girls, but do you also split in nationalities as well?
Mm-hmm.
And because I think about 2014, probably a little bit before that, was then when we see 1 million or so Polish come, and then after that is the Romanians come. I work with a lot of Romanians, a lot of the Romanians don't get on with the Romanian gypsies, and I was just wondering if you, I wanted to know that you splitting up the nationalities, and so if you've seen a big influx of a certain nationality, if you've seen on self-harm, and also if you're getting the backup when you need a translator, are you getting that? Because if not, that is something that we need to start shouting about.
The rewards actually book the translators for us, so it might delay the process in seeing them, but not really. Usually, if you know by the morning, you can book it for the afternoon, or it might be. We had a little boy the other day, didn't we? Booked it for the next day, but that was purely because of our staffing levels, not being able to see. But we do get the but obviously it makes the assessment a lot longer.
Yeah.
Because it's quite difficult then with a translator, and obviously we don't want to rely on family members because we're not going to be getting the true story. Well, we might do, but
Yeah.
so we always make sure that that's the case. I think because we cover different areas, and I suppose with Coventry you're more likely to get different nationalities anyway. So
well, that's I was about to say.
Yeah.
I don't think it'd be so much of a problem for us in Nuneaton and Bedworth, but I actually work in Tamworth, so that's where most of the Romanians are coming. Well, they actually come from Birmingham to Tamworth.
Yeah.
So we get a lot of them there. But I just wanted to know that you're getting the support that you need.
The board are really good with getting to it.
Because we're a massive team of 3.
Solid idea.
But also what I wanted to know, as in going forward, is with the Brexit thing, on another scrutiny panel where I sit on, there's been a massive rise in hate crime. So will you be monitoring that and see if that Brexit part of it has increased your workload? Because I think something like that, as in bullying,
and we also
does need to be monitored.
We do explore the bullying, we do as well, and some of the, we do our CSE screening tool, so child sexual exploitation as well, so we're asking quite a lot of questions around specific areas, and looking at, with the bullying, we're looking at in depth as to who it is bullying them and why, and reasons behind it. We try and get quite a lot of detail from that assessment as well. We're doing a risk assessment, so we can refer to relevant services. So it might be that we're linking with, say for example, if it was child sexual exploitation, we had ideas that was going on, we're linking them with the CSE team and things like that. So we do, where possible, link in with that, and obviously would link in with the police if needed. To, which we haven't.
I mean, it's a really good point you're raising, because I think it's worthwhile in a few months probably looking back and looking at trends over a period of time to see if the patterns are changing or not. So I think it's a good point, and I think it's something worthwhile looking into.
And it's, especially with the nationalities, because we don't know what they've seen, do we?
Margaret?
Thank you, Joe. Are there any plans to work with schools and teachers regarding the impact of the training and the work that they do with young people? An obvious criterion is that the numbers will fall of young people self-harming, but I think you've painted a much more complex picture than just that, and I just wondered if you would use the work with the schools to further your own information about what's happening out there and what changes are.
And just thinking of there's a team of 3 for the acute liaison team, and the primary mental health are also only a team of 3, of which 2 have just gone on maternity leave. So it's Deb was just saying, with small teams, I think there's 249 schools in Warwickshire, isn't there, alone? So our kind of mission is to find the right people to spread that message within schools, but also to give it back to us, those right people to give it back. And that's the work that we're doing, on a daily basis, is, we're linking in with the schools, saying who is the right person for us to help each other to get this bigger picture, because we need to own this together as a whole system around the child and the family. And our schools have these young people for 6.5 hours a day, and they're the biggest eyes and ears really for us to be able to work with that. But also not forgetting those young people that are not in education. We need to link with our young people, because they're our most vulnerable young people, because they're not getting anybody haunting them at any point in that day. So we make those links as well with social care. So it's a challenge for all of us to look at what's the most. I'd love for us, if there's an ambition, an aspiration, just picking up what you were saying, and what could make a difference, is our PHSE lessons that our young people attend should be a standard agenda. That would be, for me, if I could do anything in my time, that was what I would really, that's one thing I would really like to do, be able to do, is that is a standard agenda. Emotional well-being for children and people, and what it looks like, what's healthy and what's not healthy, and how do we manage ourselves. If there's one thing we could do, that would be something that would be on my wish list.
You have to wait to 2019.
19, I'll still be in work by then. Not quite retirable yet, but I think it's something about us all being able to say we play a part in this.
Yeah.
It's not just mental health, it's everybody's business, so absolutely.
Sheila.
Yeah, thanks, Chair. I think my query is around the workshops, which sounds, to be really positive, but I wondered whether during the workshops, you talked about telling the schools about the self-harm bit, but when you look at the fact that 14% of children are presenting because of the pressure to do well at school, whether there's any work done with schools, and it can be a great pressure, and there's a very great difference between pressurising and encouraging a child to do well, particularly when the ability isn't there, when you're doing your very best but you're not going to. So I wondered whether there was any work done with schools on what they could do about not pressurising, and perhaps within that workshop.
The self-harm is one workshop. We also offer several other workshops. So one's depression, one's anxiety, and one's about attachment. And we hope that all the schools come to all of them together, because then it builds a really big picture about what our young people's needs are. We hope our aim of the workshops is not only to give us some tools to our school colleagues and our social care colleagues, but also open dialogue, so it starts to get that awareness moving. I don't know what the answer is, because there is that pressure, isn't there? And it's what's the performance pressure, and what's the negative effect of pressure.
And I think that's important, because again, this is possibly slightly controversial, but I mean the school systems obviously, in very crude terms, are judged very clearly on results, and that's their driver. And I mean, we did some work with a particular school and had a class come in, and one of the things after the session, the teacher actually was really, really positive about the session, and we were talking about the potential for getting more stuff to happen in the school, but she said the curriculum is so regimented, and she's held to account for X, Y, and Z. She could not see how it could be incorporated. So it's not because she didn't want it. It was just the arrangements, the mechanisms, the framework that is so rigid. And I think unless the culture of what's required from education changes, it's almost like it's always going to be crumbs at the end of the table rather than a full part of the meal.
Ingrid.
Yeah. Thank you, Chair. For years, anorexia and bulimia was quite heavily linked with bullying. Is that still an issue? Or have you seen a decline in anorexia in young girls?
Sadly not. It's still very connected. So, and again, we could have the similar conversation about understanding the pressures for particularly anorexia. In fairness with bulimia, sometimes we don't see those young people because they manage themselves behind the closed door. But obviously, anorexia presents itself as it does, because it's a very disabling illness, and it needs to be recognised as an illness, because it is. Again, it's about us owning it as a system and helping those young people not have to feel that that's the way that they're going. So we haven't seen a decline in anorexia.
Can I just ask, and this is my ignorance, there's clearly link with bullying that you've talked about, but I suppose my question was about educational attainment, going back to that educational thing, because certainly, anecdotally, I'm aware of some young women who, because of the pressure of achievement, also, there's a relationship between them having eating disorders and the pressures in school of attainment. So I just wanted to say there's the bullying thing, but I just wondered if there's other pressures, including educational attainment, that
And
also...
self-image.
Yeah. It's a shame.
Anybody else? Right. Well, I was going to say thank you very much for a very interesting presentation. I've got loads of notes down here, pressure on other people, cabinet, further report, early intervention, what can we do to help, rotations of consultants, work with public health, communications, alignment of resources, services work better together, schools, Facebook, bullying, social media responsibility, family support workers and the links between children, mental health referrals, nationalities, breakdown of presentations, translations, hate crime, increased trends data, the work of schools, bigger picture, our old favourite PHSE, schools, workshops, different added values in school, anorexia, bullying. I think this committee has got plenty of things here to try and pull together to get it on the work programme. Yeah, would you agree with that? Yeah, and you'll be more than happy to come back and talk to us any time at all.
Absolutely.
Well, thank you very
You're
much.
welcome.
Thank you very much. Shirley.
Sorry.
Start scoping that. Yeah, where to start. Yeah, you know the way out, don't you? Yeah.
Thank you for
Yeah.
your support. It's really, really good.
Thank you. Thank you for the work you do. Yeah. Okay,
You
fascinating.
expect work to be done without any staff.
Agenda item 7, overview and scrutiny review report. Chris.
Yeah. Right. The report that I chaired is on page 16. I know that you've all read it and back to front, so I'm waiting for all these questions now. So if you've got any questions, over to you. But at the last scrutiny panel, I had it all done, passed through in about 5 minutes.
Right, which scrutiny panel was that?
It's one that I sit on.
It was
It was housing. And it's got to go to another one, Chris, is it?
It's got to go to all of it.
And environment, the last
Yeah.
one is next week. It's been to the other three, too.
The only thing I noticed was I think it was the calling procedure whereby it would be reduced to 3, one member of a panel plus 2 other council members. And I thought that was too low.
That's what it is.
So how can we always get 5 or 6 signatures then?
We didn't have to change it last year, or the year before, when there was only the 3. You know when there was just
Yes.
3 Conservatives and 2.
Yeah.
Oh yeah, they changed it because there wasn't enough. The 6 that we used to ask for, they could never have pulled anything in.
No.
So they changed it to 3 then.
Well, my view is depending on the representation of the council or the makeup of the councillors, I think 3 is too low unless there is unless the makeup of the council would indicate that 3 would be a good number. It's just an observation. Yeah. Caroline, sorry.
Chris, on page 18, number 5.A, it says overview and scrutiny should aim to show where it would be adding value. Therefore, working groups, group reviews, and ISP recommendations need to be costed. Are you saying that the actual process should be costed, or are you saying that the process could identify cost savings?
Yeah,
I wasn't quite sure about
whatever's been suggested to go forward. If that shows that it's going to be an additional cost, or what comes out of that gives the council money.
Right. Okay.
That's what that. So look, whereas we done a circus review and we allowed circuses back into the borough after 30 odd years, that has then seen an increase on income to the council. But it hadn't before because we hadn't allowed circuses full stop.
Was there a reason for that?
Because we didn't want to cruel to animals, but when we looked into it, we found that there were so many different circuses that just having a blanket ban on circuses was ridiculous, really.
Well, years ago they were very dodgy.
So we just banned circuses, and then there's people circuses, and then you've got your farmyard circuses, and then you've got all sorts of circuses, and your exotic circuses, which we still wouldn't allow.
Fleas.
So that point is just to see if it does get income for the borough.
Yeah, thank you, Chris. And then on page 22, paragraph 4.2.4, it's the public bodies that have a duty towards scrutiny and providing information and attendance at meetings. I mean, that would be especially helpful, I feel, because we've had difficulty in the past, as you know, Shirley, in getting people to attend. That's been a problem. Although, like County Council, for example, their work impacts on our borough, but they're not willing for us to ask questions about it and be scrutinised, their policies to be scrutinised. And that's always been problematic, hasn't it?
A lot of this was to cut paperwork and update paperwork, really, to be honest, and look at the forms that we had and make them more friendly, user friendly. That's mainly what we support.
But if something was set in writing and they said, oh no, we're not coming to Nuneaton, if we could email a list of their duties.
There is a list in legislation which has now been included in here, and we have on previous occasions written to county and pointed out their obligations, and they still won't attend. We can't do anything else really. The only alternative, which is always sort of put forward, is that you sort of name and shame when they're invited and don't come. The panel is within its rights to say and minute that they were invited and refused or didn't attend. But I mean, that's at any time, but that's down to the panel. I mean, it's even been known elsewhere to be put in the press that people have been invited and have not attended. So I mean, there are ways and means, but it's just about how, as a panel or council, you want to approach it.
Well, if it happened under my chairmanship, I would definitely be writing to the chief executive of the relevant county and directors of the relevant who these officers work for, to let it be known firmly that we expect, if they are representing and handling taxpayers' money and providing services for the residents of this borough, then we expect them to turn up and talk to us. We're not an inquisition, you know. It's the least they can do. Okay. Anybody else? No, so we take the recommendations and send it off to the Constitutional Working Party?
No, Chris has got to take it to Planning and Environment next week.
Yeah.
And then if all four have approved it at that point, then it will go, I believe it will go to management team, because obviously a lot of this is about their systems, and it's intended for it to go to council on the 24th of April.
That okay? Yeah. Yeah. Okay. Thank you very much. Thank you, Chris. Agenda item 8, Teenage Conceptions Review Report, presented by me. Well, Shirley, thank you very much for a very good report. I think the majority of the people, 1, 2, 3, 4 of the 9 people here, worked on the review, 5 of us worked on the review, and it was a very, very interesting review. Actually, there was some good things, there was a lot of good things that came out of it. Let's not be shy about this, you know, keeping Hatter Space Health Centre open, you know, when the county were going to close it, was a major win. The idea that we also had a conference whereby interested parties throughout the borough and came together and promised and stood up and said how much they realised the problem with teenage conceptions within the borough in 2014, and also the joint working that will go on with North Warwickshire into how we can monitor and reduce future teenage conceptions. They did go up to 43 per 1,000 in 2004. We were the worst in the country, hence the warning signs were there, and we have carried out this piece of work. I'm pleased to say that the figures for 2015 were down to around 22.3. I don't think we've got them there. We've had the latest figures just come through. So I can't quote me on that. But although that would continue down to the downward trend that we've been seeing, I'm very, very sceptical on whether or not that will be maintained going forward. So I think our recommendations, which are to receive a progress report on the matter from Warwickshire County Council Public Health Service and how they're going with the work that they promised to do, a request for feedback and progress made to the schools that provided evidence of this review, together with any other schools using the Respect Yourself and Associated Public Health Services in the interim period, and request a report back in October 2017 from the Addressing Teenage Conception Task and Finish Group, so we can be updated. I don't think we've got to take a foot off the pedal on this. I think it's something that...
to monitor it.
Yeah, and obviously keep the pressure up on PHSE. Now we've done the report. Like I said in my closing statements, I'm really pleased that politicians across political parties have recognised at long last that PHSE, and apart from exam results, it's the whole culture of the human being, the child, that really matters, and they've got to step up to the plate. As I said in my report though, I am very disappointed that it isn't coming into 2019, and it scares me that it will be kicked into the long grass or something like that, so we need to keep the pressure on. So, any comments? Anything you wish to say or accept the report? And Margaret?
Chair, thank you. Can 4.9 of the report, where we've put concern regarding the lack of commitment from schools, do you think we could put in there that the reason being that, you know, it isn't a mandatory
Yes.
subject, and therefore, you know, the schools and the pressure that we've had, because I think we heard it again tonight from the acute team, and it, you know, that pressure in schools for exams, and I just thought if rather than just say, you know, that there is lack of commitment, which is right, the reason being that it isn't a mandatory, they don't have
Subject.
to do it subject.
Yeah.
And it just supports our case a bit more as well.
Yeah, I totally agree, Margaret. We can do that, surely, can't we? Yes, of course we can.
Sorry, Sharon. Just a couple of sentences.
Just a couple of sentences on 4.9, because it was, you know, when we did talk to, especially at the conference as well, when we talked to representatives from schools there, they said, well, we haven't got the time. They all tended to agree it would be nice to do, but how do we do it? Who's got the skills and who's got the training to do it? Although the county can provide that, they've only got to ask. Ingrid, do you want to say something?
Just typing error, 3.4. 2012, 3rd of July 2012.
Of course. Cool, we haven't been going on it that long. It's only been a year.
Sorry.
No, noted.
Yeah.
Noted, thank you.
And the other thing, Jack, we're talking about not taking, foot off the pedal.
Yeah.
I wonder, you know, we did a letter, didn't we, that, you know, to send to the panel, which, and obviously, you know, it's now been decided that it'll go to 2019, but I wonder, you know, because it was a good letter, that if we couldn't use that to sort of say, as you have said, the disappointment that
Yes.
it isn't going to come in until 2019.
I think that's a very good point. Now we've completed the work, and the work is obviously first hand, you know, that we can draft a letter saying we've done this work, we've done the report, we can bring the letter up to date and then state that we are alarmed that it's not coming into 2019. Yeah, we can do that, and we can send it up to Justine Greening and whoever. Okay.
Do you want to send a copy of the report with that?
Where we can do, yes. Yeah.
Just a point really, so you say you're not going to take your foot off the pedal, so what you're going to do to keep that here on this agenda, and how are you going to note it like as a graphic of teenage pregnancies sort of now, next year, the year after, up until 19. So if you see a steady rise, so we did bring it to your attention back in 2016, 2015, whatever.
That's right. Well, we have data going back to 1998 in one of the appendices. We've also got the work that's supposed to be, that will be going on following the summer responses, which will be monitored, right, with all contact people there. We can have those back. And the North Warwickshire Teenage Addressing Teenage Conception Action Plan to 2016-18 is up in one of the appendices, right, and that will be monitored. We can monitor that as a scrutiny. You know, they've got aims, and there's a blank spot there that says progress.
Chair,
So hopefully that will be completed.
I'm sure Luke Carter would be happy to come back and update.
Yes.
He's the knowledgeable guy for all this, and is very helpful.
Yeah. And the JSNA report will come each year, which identifies.
You know I love the JSNA, but the job of the scrutiny is to make a noise, isn't it? Really.
Well,
You need to make a noise and keep it here.
yeah.
I say we did make a noise then, you took no notice, the following year it was up again, and the following year it was up again.
Yeah. Well, we can do a lot of that through the North Warwickshire Addressing Teenage Conception Group and the action plan for 2016-18. It can be refreshed, it can be revisited, it's got to be kept up to date. we have the only trouble, yes,
I was going to say the CCG are involved in that as well, aren't they?
yes, yeah, everybody's involved in it.
So it's quite a heavy group.
It is. So we'll make the alterations to the report, send off the letter to the Education Minister and the other cross-party MPs that brought it up in the first place, Sarah Wellington, Labour, and somebody else, there was 3, wasn't there? Okay, and we'll put it on the work programme to be revisited, like I say, later on in the year, and then going forward as a standing item, possibly just for an update each time.
But we'll certainly review it in 12 months.
Yes, definitely. Definitely. Okay? Anyone, item 9, the STP. Anyone heard anything? Because I've heard no more.
Nothing.
Nothing from my contact at the hospital.
No. Just
I asked Rachel today, Chair. She said that she hadn't heard anything. There was a little bit of something around some maternity services, but that they're still saying that it's not a public document.
I think this might be another U-turn.
They have done, well, they didn't call it a consultation, a survey or something of mums, maternity women. But as Shirley's just said, it's not a public document. So that just makes you wonder, are they looking at closing maternity? Otherwise, why are they doing this survey thing? So
what was the survey on?
it was pre and postnatal care, I think, and delivery, maternity care.
I think it was about, thinking back, I heard that it might have been about where babies are delivered, whether or not they're home births, hospital births, and how mothers felt about the options that they've got. Now, whether or not that was leading, there's one argument therefore that it might be leading to you have more choice, right? You can have a maternity-led unit as well, wasn't it? You can have more choice if you have more children, have 40 children at home, as against having them in hospital or with a consultant required, or there's the midwife-led wards. So I think they're doing some work as to looking at what options mothers might prefer, or historically how in the past 12 months or whatever, how many births have taken place at home in a midwife-led ward or more serious
we've had
cases.
These options up north for decades. We've had birthing pools and all, so we're much more advanced up there.
Well, we'll leave that to Phil.
Chair, we don't want to again be accused of scaremongering.
No.
The problem we've got, and I think we should express the view, is the lack of information coming out about it.
Yeah.
And I should remember, I previously declared an interest that my daughter is an employee at one of my daughters is an employee at George Eliot. I don't know whether I have to keep doing that or not, but there's no doubt there's something happening there. We had the assistant manager or whatever the title was, saying there's no risk. Staff at maternity were told that there's no risk to maternity, but I deliberately asked them when they were here the last time about maternity services, because it's the terminology within the document that says there will be no loss of maternity services, that sort of thing. No. What it doesn't say is where those services will be provided.
Yeah.
And we still had no answer. They couldn't answer it. as I understand it, there's a regular journey of midwives being seconded to the Walsgrave, call it Walsgrave,
Yeah.
for want of a better. And there is a concern there. I deliberately asked a question of these people here today about paediatricians, because you've got, trying to compare it to places up north, I don't know, I can't compare it, I don't know. What I do know is with the maternity services here, they are recognised nationally
Yes.
for some of the initiatives that they do.
Yeah. Just won an award.
But the problem is, if a paediatrician is removed from the George Eliot Hospital, then you can't run the maternity service anyway.
Yeah.
So, I don't want to be cynical and have all conspiracy theories like somebody else that comes here regularly would probably have, but it's a concern. And I think, not just around maternity, but the whole process of this, is we should be making our voice known. Chris has just said earlier, sometimes you've got to shout and nudge people, and they are not telling us what's going on.
I agree. It's still second-hand rumour, gossip, you know,
Anecdotal stuff, you know, and
which is no good to us at all.
but I've been around these issues a long time, Chair, as you know,
Yeah.
and I saw it with St Cross at Rugby. I campaigned over there with the people from Rugby. What happened? They shut their A&E and, you know,
Yeah.
various things.
Yeah.
And there was a guy on the telly the other day saying the local one that is most threatened is the George Eliot Hospital because of its size.
Yes.
And
Yeah.
the trouble is, we get accused of scaremongering when we express our concerns. It's not scaremongering, it's expressing our concerns.
Yeah, we just want some facts on the table to know. So residents then know, and residents can make a decision, or there can be an argument for the case for or against. My argument is change will always happen, but people want to know what the change is, you know, so they can make a valued judgment on it. And also, I also find it quite strange that when you don't get information, obviously people are going to be worried. If things are so good and things can happen and services can improve through change, then put it on the table and let us see it. And until you put it on the table and people can see it, then they're going to be worried. You know.
Chair, I think my big issue with STP is, like you, I don't mind change, but the change isn't clinically driven for better clinical outcomes and so on. It's this 267 million that's got to be cut. That's what's driving the change, and that's what worries me.
Yeah, well, that's an opinion.
I think also what you need to do is, I mean, everybody knows I don't want to change, but you need to remind people of what we've already lost. I mean, you could probably bring in St Cross into that, because it's only just on the motorway, but we've already lost Marrow, Bramcote, now the Elliots there at the threat again. Perhaps bring in St Cross. I mean, I was there and there was a brand new children's ward. Never been open, never been used, closed it. You know, we need to remind people of what we've already lost.
Well, from my own personal point of view, Chris, Bramcote was a major loss. Absolutely major loss. It is showing now, you know, when we haven't got places for patients to go to recover before they go back home. Additional places, although there are places within the George Eliot at the moment, additional places that's required.
The respite care as well.
Yeah. Yeah.
Did the George Eliot engagement exercise happen?
I don't know. I did contact them, but I never got a response. I haven't heard anything from Shahana since she left the meeting.
She was supposed to invite us to something,
Some
wasn't she?
information, yeah. So I don't know.
don't think it happened because I haven't heard of anything.
Well, I'm chaseable.
It's been and gone. March the 30th.
30th,
Yeah.
wasn't it supposed to be?
Because we never heard about it, did we?
Yeah.
Afterwards.
Trish?
Do we all agree that we can't let the maternity unit shut down, even if every mum says, yes, I'm happy to have my baby at home? do we all agree with that? Because you just, both of my babies will rush to special care and not breathing. You know, no way they'd have survived.
No.
And I'm just wondering whether people think, oh yeah, I have a baby at home, that's lovely.
No,
we don't
no.
need a maternity unit, or you
As
all
far as-
sort of think, yeah, we need it, we need to
Until,
hear it.
from my point of view, and maybe it's the panels as well, is that there should be no changes to maternity provision. Well, there should always be maternity provision at the George Eliot Hospital. What form that takes, I've yet to see of what change they might make. You know, but there should always be maternity provision at the George Eliot site. And my reasoning for that is geographical as well, you know, because those in the north of the county, you know, it's difficult to get to URCH. Yeah.
Chair, and when you look at it, it's always women and children that lose services, isn't it? Why is it?
Well, you have to ask the great and good about why women seem to be more penalised in welfare, benefits, services, etc. But it's far greater than this committee. I'm sure we would put it right if we had the opportunity.
Chair, just a thought, it may be worth having another conversation with Housewatch
Yes.
and seeing if they've got any, you know, anything sort of dripping into their...
I can quite
Yes,
happily
as well.
get in touch with Chris. He's, when I went to the adults, the Health Overview and Scrutiny last meeting at County, Chris said he was more than happy. Please invite him back. Yeah, so we can do that at our next meeting, or I can be in touch with him beforehand.
Just one point coming on what Trish just said, is I was a bit shocked really that woman said that there wasn't enough babies being born at the Elliot. So I'd like to see some stats on that. Some stats on that, perhaps over the past 5 years, if we could do that, and perhaps on surrounding towns or boroughs the same size of us. So we've got something to argue with. It's no good just taking a person's word for it. If we've got something like, say, Rugby, and they've got less babies being born at their maternity, I don't even know if they've got a maternity, so. But if they've got less being born there, and then at least we've got an argument. But if we have actually got less babies being born at the Elliot, there's a problem somewhere. So I think we need to have some stats, and stats from the same sort of boroughs, sized boroughs.
Okay, so it stands an ongoing item.
Considering we didn't have anything to say, we've done
Consider we didn't have anything to say.
Maybe we should come now.
Right, I want you to bear with me here because Chair's update from ASC HOC. I'll tell you what was on the agenda, and when I started looking at it, to be perfectly honest, I forgot how much was in it. So I haven't been able, in a way, to disseminate or break it down into anything that would be... There's too much. I mean, what we did go on about, there was the care homes issue, which was a follow-up to the progress and developments over the previous year. The one organisation plan performance, which basically illustrates how services are having to struggle with, to be polite, less money than what they had in the past in reference to health and social care. The joint strategic needs assessment, there's an article on that, and the big thing that we're doing in quarters, and also I think an advantage for us in the Nuneaton and Bedworth, is the fact that it is going geographical. Right, it's going place. Right, so if we took, there'll be, I think, up to 15 to 20 geographical areas right across the county, and so instead of concentrating on a particular illness across the county, they'll take a place and look at everything within that area, the types of illnesses within that area and everything else, and we can, and thankfully we are going to be ahead of the game on that, because I've asked Public Health to actually send us through, as soon as they have it, the first amount of data that they've got for the Nuneaton and Bedworth before they do any more, you know, because we have quite a good relationship with Public Health, and they've promised me that they will do that.
Well, that might help with what Chris has just said, and comparing other areas, like if they've got maternity.
Well, we've got,
care,
I think the point is that it's sort of like having the joint strategic needs assessment, but it's too broad. I think the feeling is now they've got enough data and enough knowledge after 2 or 3 years now to start drilling down, right, and putting resources into where they are required, right, at ground level, rather than looking at the big picture and saying, well, everyone's got diabetes across the county, you know, let's deal with it from a county-wide issue. You know, we will know where our biggest problems with obesity is, or things like that, but then Public Health can use the finite resources that they've got to get in there and hopefully make changes. There's never enough money. There's never enough money, but we've got to hold Public Health and the county to account, whereby resources have got to go where there is proven need. You know, we've known this for a long time in the Nuneaton and Bedworth, that there's been proven need, but no one's taken any notice of it. I think since Public Health have settled into becoming part of the county, and it's only my own view, that settled into becoming part of the county, even though they have their own funding, they are quite data driven, right, but they will put their resources where they're required, you know, so it gives us more leverage because they can produce the facts. Okay.
The reports and minutes are available on the council's website.
Yes, if someone would like to
wants to
look at them, yeah.
Got a way to go down there.
I'll just try and digest it better. Yeah. Work programme.
The work programme is at the back or what's left of the work programme is at the back
What we've been doing.
of the agenda. I had hoped, because I've taken it off there, but also today we were going to get a presentation or a report on end-of-life care. I understand, having had several emails backwards and forwards from George Abbott Hospital, there seems to be some issues around end-of-life care. And whilst I finally got the name of a contact there to try and get hold of, I haven't actually managed to get hold of them. So
It stays on.
we can add that back on if you wish.
Yes, definitely.
And similarly, Chris, with the discharge protocol, nothing. I asked for...
On that, I thought we was going to put a date of when it first went on.
We haven't had the recommendations approved.
No, but looking at that, it looks like it's already gone on 2016, 2017, and they were dealing with it before that.
Yeah,
So I
but
wanted
it's in
the
your
date.
report.
Doesn't matter, I wanted the date of when it first went on that work programme.
When the recommendations of the report have been approved by all the OSPs, that will happen.
Okay.
You're jumping the gun. So yes.
Right.
I did ask housing as well to get involved, because I think Jed wanted to hear from somebody from housing, and discharge protocol was related to housing. So
Yeah.
I have made the noises in the right places. I also received yesterday, I think it was, an additional item from Councillor Margrave, and he's asked if the panel would consider putting on for next year hospice bed provision in the borough. He says that he's had personal experience of an issue that's related to that, and would like for that to be added to the work programme.
I got a copy of that email, look, it came to both of us,
Yeah.
and I'm more than happy for that to go in as a piece of work.
It links with end of life care, doesn't it?
You know, depending on what the panel said, but I'd like it to go on. I don't know who's going to be chairing it or who's going to be on the panel next year, because this is our last one, I think, present moment in time, but I would like that to go on. And also, following the presentation tonight from Jed and the ladies regarding young people and self-harm, I think that is something that could be delved deeper into. You know, like I said, there's a lot of different areas there. I'd like to see that go on the programme as well. I don't see that disappearing or reducing anytime soon. Trish?
Regarding that, and Caroline's comment about the kind of rise in young children with panic disorders, it is autism awareness, something or other, and I did a training session at college yesterday, and I wondered whether I could do some autism awareness and kind of why it's risen, how to solve that issue you've got, just like that. Ooh. and all the connections with what's happening.
Do you wish to do a presentation, or do you wish to have somebody come in?
No. I've got all the stuff. I've researched it for probably 10 years.
Yeah.
And I've condensed it down. I could make it a 45-minute presentation if we wanted it.
I would definitely.
Yeah. Yeah, if you're willing to do that, or just...
It can go on as an item
Yes.
for 1 week.
Yes.
Does it, the gambling one, does it link with, like, gambling and addictions and things? Does it?
I've got to do some more research.
Oh, sorry.
Okay.
I don't think so, but I'll have to
sorry,
research.
I just wondered if there was a link.
Yeah. And that's ASD. Yeah, we can arrange that. Yeah. We can put that on as an item. Yeah. And with that, are there any other items? No? Well, on that note, I'll close the meeting. Thank you very much, Shirley, this year, and thank you all for your contribution throughout the year.